You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Hello, this is Dr. William Wiley. In this episode, we'll explore how long-standing misconceptions have shaped the field, the evolving patient perceptions of refractive procedures, and the broader impact of challenging these myths on patient trust, outcomes, and innovation. Joining me are Dr. John Doane and Dr. Michael Greenwood, both of whom bring valuable insights into how myths influence both patient decision-making and professional practices. And I think we've all sort of benefited, but also had some negativity regarding myths. I think to myself initially, it's easy to overlook some of the benefits we have from myths. But you think about just laser eye surgery itself. That term carries so much power, and we've all benefited from anything laser. Patients think laser is magic, and when you apply a laser, they're all expecting near perfection. And it's one of the greatest marketing terms we have in our business. So you just apply laser to anything: laser cataract surgery, laser glaucoma surgery, laser refractive surgery. Chances are it's going to be, the perception it gives is this perfection. And so I think we've all benefited from that, but we've also seen negative myths in refractive surgery. So John, what do you see as the biggest, negative myth that's out there that that we could dispel in refractive surgery?
I totally appreciate your points, Bill, on that. Maybe the misconception for patients is that, and I think for surgeons, the expectation is 20/20 and spectacle free. I mean, and now when you have surgeons coming out and saying, it's 100% guarantee, sometimes we'll see that, or better than 20/20. And when we talked years ago about doing supervision, we've now raised the bar so high that any patient that comes in, I think they have to be expecting literally never going to be in glasses, and my vision's going to be equal to what I was in contacts or glasses. And that maybe is a little bit stretching the envelope for 100% of the eyes. I mean, granted, we do fantastic work, don't get me wrong, but sometimes we maybe make the oversell versus the underdeliver a tough thing to make up for.
Yeah, it's a good point. I often think that technology is constantly improving, but at that same time, we have patient expectations that are improving. And so sometimes I think we get caught, behind that curve, and the patient expectations are often outpacing what we can deliver. Mike, what do you think? John and I have been at this a little longer than you. You're newer to it. Obviously, you're established, but that generation or so behind John and I. And so, what do you think about the current expectations and that we've set?
Yeah, I mean, those are great points that you mentioned. And as you were talking about it, I'm thinking of patients, that I've seen, distantly and very recently, of that same thing of like the expectation is so high not to be as good as my current contacts or glasses, but better. I think we've all done refractive surgery, whether it's cataract or, corneal based, and they're like, well, I can't see the end of the aisle at the supermarket. And we're like, well, nobody can, And so I agree that backing off on those expectations a little bit. The other, more common myth on the patient end is, hey, I have astigmatism, so I can't get LASIK, right? And so we're still kind of, even though you guys and everyone else has been saying that for, 30, 40 years that we can do that, people still wonder, well, I have astigmatism, can I have refractive surgery? So even on like the most basic level, we still aren't getting the message across. And I think it's not that we're not saying it, it's just the people that need to hear it haven't heard that message before. So we as surgeons and a community just need to keep repeating messages over and over and over again, because we're going to get tired of hearing them. But the patients, they either haven't heard them or haven't heard them enough, or they're brand new to the scene and looking for refractive surgery. And so even just the simple ones, I think we need to continue to focus on.
I think Mike's point is I simply have to laugh so often. I had this really a week ago, and I repeat this to our staff. It's one of those annual repeats. And it's like, 365 days of one-day training. Patient comes in. My doctor has told me for 10 years that my astigmatism can't be treated. And I'm thinking, when they say it's their doctor, and so I'm thinking, is their doctor just not want them to have surgery? Because it's been very clear for 30 years. We're almost 30 years into the FDA has approved excimer lasers for astigmatism. This is not something new.
Yeah.
Yeah, that's a classic one. Now I wonder, could it be like lost in translation? Is it presbyopia that they don't quite understand and they're mixing that term?
No, 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 no. This is plain simple astigmatism. Yeah, there's no. This is not a presbyopia question.
Yeah. But
Yeah, yeah.
you bring up another good point too of, another myth I was thinking about is a lot of times people come in and they're like, "Hey, I was told I'm not a candidate for LASIK." And that can be, almost anything like you said. Maybe it was during that time where we couldn't correct astigmatism or we couldn't correct hyperopia or, the lasers just weren't as high tech and as safe as it is these days. And so they still might not be a good candidate for LASIK or, a cornea-based procedure, but we've got these other procedures, whether it's ICLs or refractive lens exchange, that can help, and the safety parameters have grown over time. And so I think one other major common myth that we just don't, I guess maybe it's not a myth, but it's I wasn't a candidate for LASIK, so I'm probably not a candidate for anything. And now that we've got bigger parameters on safety, efficacy, and options and age ranges, that's a big thing that I think can be tackled.
Yeah, that's a good point. Yeah, do you find yourselves talking more just refractive surgery rather than LASIK eye surgery or laser eye surgery? Do you think, as an industry or as a profession, should we move towards that? Because now with refractive surgery, we do have so many options with um, multiple corneal procedures, implantable or ICLs, refractive lens exchange, all these different options that likely are going to be an option for somebody. And should we be trying to paint a broader brush like that, or does it help the market, confuse the market? Is it easier just to fall back on laser eye surgery, and once they're in, then change, change the message? I'm curious what you all are doing.
I think your point's well taken. So I think if you do let's say a direct marketing campaign for the entire population of refractive surgery patients. So let's say age 18, let's go out to age 80. We know from 18 to 40, laser vision correction is great. From 40 and below, ICL is great. Okay. The one thing that we run into where I think it can be a real problem is, let's say you do laser vision correction on somebody that's 25, they're now 45. 20 years ago, and they love the procedure, absolutely loved it, but now they're presbyopic, and they can end up telling their friends, hey, my laser wore out, my LASIK wore out. Well, no, 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 no. Your LASIK didn't wear out. The lens inside your eye wore out. So you could take that marketing stance of saying, put this on ABC News and tell the entire world, hey, did your LASIK wear out? Come to see us for refractive lens surgery. Well, now the refractive lens patient may say, oh, yeah, this is awesome. But now you marketed to the whole population that hasn't had LASIK, that LASIK wears out. Well, no, 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 it doesn't. So you got to be careful in the group that you're messaging. And so I guess my point is, I think you do have to stratify your message to the age group of the patient.
That's a good point.
And our strategy, it's always in flux, but when patients understand LASIK, if you say, hey, come in and have a refractive surgery evaluation, they're like, I don't know what that is, but that doesn't sound like what I need. I'm looking for LASIK, and you're like, oh yeah, it's the same thing. And so for better or worse, it's kind of ubiquitous, like Kleenex, instead of tissue paper or whatever, you know, it's a Kleenex, and LASIK is LASIK. And then once they get in your office, then you can kind of guide them where they need to go. And so, a lot of times if someone comes in and they're not a good candidate for LASIK, we say, hey, you're coming in for LASIK, but we'll do the same thing, get you out of glasses the way you want to, but we're going to go with this approach, and do it that way.
We do virtual and live consults, and it's really interesting. We'll throw out virtual consults, 3 or 4 years ago. I'm thinking the virtual consult, it's going to be a 40 and under person that's coming in for laser vision correction. Yay. Well, it turns out we'll have people that are 65 or 60 or 70. And so you have to figure out, well, had they had prior laser vision correction, or no, we're absolutely not doing laser vision correction. We're going to do, refractive lens, or no, you may very well have cataract. So I think it's, Bill, kind of what you're leading to is we're just starting a conversation on correcting refractive error. If that's presbyopia, happy to correct that. If it's hyperopia, astigmatism, myopia, happy to correct that. So it's just starting the conversation. And I think that, yeah, LASIK can be the entree, but it may very well not be the thing we're going to recommend.
Great point. Do you think it, knowing what we know now, do you think it puts more pressure on all of us to have better informed consents where you kind of want to set the stage for that 22-year-old to set the stage? So, okay, this is what's going to happen in your lifetime. You're going to have X many years of LASIK. And then when you turn 40 something, like everybody, you're going to start to need reading glasses. And eventually you're going to then, not only need reading glasses, but you're going to have blurred vision. You're going to need cataract surgery, whatever it is. I think if we set that stage, I think it sort of takes away that surprise. Maybe it helps mitigate that, quote, LASIK wore off. It's sort of, no, this is what LASIK did great, but my eyes got that much older and this is what happened.
Yeah, I agree with you, and it is sort of the informed consent of, hey, here's what's going to happen, and that's why it's hard. John mentioned at the beginning, like the lifetime guarantees and those types of things, where it's hard to not upset somebody if you say you're going to have a lifetime guarantee, they do surgery, and then their lens is an issue. It's not the LASIK. It's, the lens has changed, or they've got dry eye or something like that, and they come back and they're like, hey, fix it. And you're like, well, no, I need to tell you about this thing. And then they feel like they're kind of getting drug along. And so, yeah, I think you're totally correct in it's, hey, here's what's going to happen now. Here's what's going to happen, when you hit this age, and here's what's going to happen at that part. So it does take more time, but it is important.
Here's one, Bill, that's kind of getting into the weeds a little bit. I've said for years, when we talk about, let's say, IOL patients, and now the discussion with IOL patients, well, is the lens ever going to wear out? And so, for years I've said, well, there's three variables in what's going to change the power of your eye. Your eyeball is going to lengthen or shorten, and I'll say, well, I think that's very unlikely. I'll come back to that in just a second. The inanimate object we're going to put in your eye, highly unlikely it's going to change. If it doesn't change position, we're good. The last thing you have left is the cornea. And yes, there are some people, the cornea will change over time. They'll get some astigmatism. The overall power will stay the same, but they'll get some astigmatism. We can't really, predict who that's going to be. And I'll say, I had LASIK almost 29 years ago. My corneas have not changed at all. My distance vision hasn't changed at all, but it's gonna, as soon as I start getting cataract. And the one thing I have said for probably, it's almost 30 years, I said, you get to a certain age, your eyeball length will not change. Well, that was one thing I said, I told myself a long time ago, never say 0%, 100%. That means I can predict the future. Cannot do it. Lo and behold, I've had two patients, one, an ICL patient that I did IOL master on 12 years ago, and she's now 45, and damned if her eyeball length didn't lengthen. She's lengthened a millimeter, and she's now a -3 diopter myope. And another guy that's about 45, I did LASIK on, and then subsequently he got cataract. I did his cataract surgery, and he was, so I had IOL masters on him about 10 years ago, and he went to -3, and I go, can't be. Did IOL master? He's changed a millimeter. So eyeballs lengths do change even into your 40s. So I learned something new. So we can never ever predict. So if we tell people you're never going to change, maybe not.
John, I think you totally nailed something. I think it's much more common than what we understand or believe. I've had 2 or 3 ICL patients that have had that same scenario that you describe. And it makes me wonder, ICL, we obviously do routine IOL mass or axial length on them. And so we have that documented and we can see, has it changed? It makes me wonder about, the patients that have had LASIK that then had this myopic change. And then we think, well, is it the lens changing, or did they have epithelial hyperplasia, or what's going on here? Might it simply be that those eyes got a little longer? And is it more common than we understand it? Obviously, with the LASIK patients, it isn't or wasn't routine to do axial length measurements. But with the ICL, we do witness that and have that documentation. So I do wonder if it's going to be if that's one of the more common causes that we just never understood.
Yeah, it has to obviously be I mean, we know that with NSC, people are going to get more myopic, but like these two patients I'm talking about, they were, higher myopes. So we're talking, the one guy was a -9 starting out, and the lady that had the ICL was like a 13 or 14. So they were extreme eyes to begin with. Would a relatively normal length eye, is it going to lengthen? I don't know, but these people that are extreme, maybe they're setups to continue.
Right. All right. Well, great discussion. Let's change gears a little bit and let's talk about some of the myths or realities you're discussing refractive eye surgery that come up all the time. Let's say two that are common within corneal refractive surgery is pupil size. Does it matter? Does it not? And dry eye. Does corneal refractive surgery cause dry eye or not? And so I'm curious what your thoughts are and how you handle those questions, and going into informed consent and setting informing the patients properly, but making sure, but not perpetuating a myth that's not true either. So I'm curious how you handle those two things in corneal refractive surgery.
I'll do my best to answer both of them. And so on the pupil size one, you know, for context, I finished residency in 2015, finished fellowship in 2016. Um, and for cataract and LASIK patients, we would look at pupils. And then over these last couple of years, we've just kind of stopped looking at pupils altogether. And there's been a couple things that have helped with that. Actually, the reason why we look at them now is how well do they dilate, but not what their normal, photopic, scotopic pupils are. And to me, this kind of points back to the safety profiles of the lasers and everything else. Like the technology has gotten so good with the blending of the peripheral cornea and these myopic treatments that glare, halo, and running into kind of that like very sharp, contour change in the cornea, right where the pupil border is, where they'd get all this glare and halo. That's kind of gone away, with the modern lasers and the technology. So I don't really pay attention to pupils. I will mention it, in the exam lane when I see patients. I'll be like, hey, you'll get glare and halo. That'll slowly fade with time. Or, hey, you've got abnormally large pupils. When I'm talking to you, your eyes are almost like dilated. So you'll probably notice glare and halo more than the average person. But as time goes by, you'll get used to that. Either your brain will adapt or your eye will start to adapt and it'll start to shrink down. So just be aware of it. And I make sure that I consent them with it, but I don't really change plans or kind of go overboard with it. And I forgot your second part of the question, but I did have an answer for it.
Hey,
Dry
listen.
eye.
Oh yeah.
Hey, Mike. Let me jump in on that. We'll stay on pupils, then we'll go to dry eye. So I'm kind of like Mike. Years ago there were several lawsuits that were huge, that were $5 million lawsuits on pupil size. I mean, there were so many of them. In my experience, if you're going to have symptoms and you're going to try to relate it to pupil, I would say if we have complaints, halos, starburst, whatever, 95+% of the time it's residual refractive error. If you correct the residual refractive error, the scotopic symptoms go away. The remaining 5%, it can be just about anything. But I think the critical piece of information is the treatment centered. If it's centered on the visual axis and the refractive error is near zero, I think it's near zero that they're going to have symptoms. In fact, I would say so much if somebody was anoretic, and their treatment centered, the likelihood of them having symptoms is remote. But if you take you think a great laser, whatever, and you decenter the treatment, which is very hard to do anymore, you're going to have symptoms because you're going to create coma, and the patient is going to be very bothered with that. So I think it's all about centration, and for all practical purposes, I don't really look at pupil size much anymore because I've just found that it's not been an issue in years as far as complaints with patients. So I just make sure that they're on target and the treatment centered, and what the types of techniques we're doing now, the likelihood of decentration is basically non-existent.
And I think the other, just to put a bullet point on this, like there are studies that have come out recently, patient reported outcomes of like, hey, glare and halo, it happens, but it's not bothersome or it goes away. And so this data is out there, but it's kind of sporadic and it doesn't maybe get celebrated as much, or kind of regurgitated over and over and over again so that everybody hears about it, surgeons. And then I don't have a great idea of how you get it out to patients other than just keep continuing to talk about it. But I think that's how we kind of have to bust these myths, is repetitive information over and over and over again, especially on these safety ones. And you didn't ask this, but when you talk about like ICLs, like the ICL technology has shifted dramatically in the last 5 years, and the safety profile has gone way up, comparatively. But there's still people that are like, well, I heard they're not safe. I heard they're not safe, from this reason. But with the newer technologies, they couldn't be. I mean, I guess they could always get a little bit safer, but it's so safe to do it now. But people are still hanging on to the old data because the new data hasn't, been through the systems as much as it needs to be.
Yeah, I think another point that I'm cautious of is that I know what my experience has been. In patients that I've seen, there may be a patient somewhere or a surgeon somewhere that is, dogmatically says that pupil size is key, and if you violate it, you're going to run into a problem. As I look at the data I think is overwhelming. That again, if you're refractively neutral and you're centered, the likelihood of having a problem is really low. But the lay press is so right word, so aggressive in some cases. If a surgeon comes out and says, I just don't see it as a problem, they kind of jump on that surgeon and say, that he's not telling the truth, which is simply not the case. Not my experience.
Yeah, no, I totally hear you, and it's challenging. When I see a patient that comes in the office with large pupils, I feel compelled to discuss. I might say something like, "Well, if you were to Google, you'll find a lot of things online about large pupils and glare and LASIK. So I want to get ahead of that, and I don't want you to worry. And so you don't want them to just first read about it because they see their pupils. They're like, "Well, I know I have large pupils." They Google it and they see hundreds of things on there about the negativity of that correlation. But I try to get ahead of it. I said, "Listen, the real studies show that there is really no correlation." But I do say, regardless of pupil size with LASIK, there is a chance of glare. The chance is low. And like John said, if it's well centered and with the newer technology, that chance is very low. But I said that with any patient, there is that chance. And so regardless of your pupil size, that is a possibility. But I don't want you to be concerned that you're this outlier because you have this large pupil. That we treat plenty of patients with large pupils that do great. But with any surgery, there are risks, and so it's good to understand that. Something like that. So I preface it, and I try to make them feel that they're not this outlier, but I don't want them to find it out first on Google and make that correlation themselves.
Hey, Bill, on that same line, when we go to and talking about dry eye, if you don't mind me shifting to
Sure,
that,
yeah, that'd be
I
great.
think the issue becomes looking at big data, and the big data would say that pupils don't matter, and the big data would say that laser vision correction, be it PRK, SMILE, or LASIK, does not cause long-term dry eye. I don't want to discount the individual that says, "Oh, gee whiz, I'm having these symptoms." I can take the counter that 29 years ago I became contact lens intolerant due to dryness. I did have some GPC. The second I had laser vision correction, the symptoms basically went away. I haven't put a artificial tear in my eye maybe one time every 5 or 10 years. I just don't have the symptom. But if somebody has had laser vision correction and says, now my eyes are definitely dry, I say, okay, I'll buy that, but I will also tell you we now have 30 years of data that shows that there are less dry eye symptoms, or you go back to baseline at 3 months to, so 90 to 120 days. The large data shows that the patient population is back to baseline.
Yeah, and I think it's so hard to prove. I mean, having all that data is perfect, and it's hard to. The hard part with that is it's hard to prove the opposite. Like I haven't had cornea-based refractive surgery. I have ICLs, but my eyes are more dry now than they were before I had ICLs. And it's not from the ICLs; it's because I'm 15 years older. And So like I got older and our world has shifted and changed. Like we're so digital focused now. We're just not blinking, doing all the things, that we need to do to take care of our eyes. And so age and in a new world is what is affecting me. It's not, anything to do with refractive surgery. And that's the same with these patients. They have refractive surgery when they're younger. They get older. Dry eye is more common in older people. And so, finding a way to dispel that, like you said, is perfect with having those baseline measurements. And again, it's just part of the discussion with patients and trying to dispel it from the get-go.
On that same line, that I don't, we don't talk as much in the last maybe year to 2 years about corneal neuralgia. I just think about, you touch an eye, somebody has cataract surgery, and all of a sudden, I've got this feeling there, this, I think it's going to go away. But I think just touching tissue, you can excite a nerve, and that nerve may, fire off here and there. Same thing if you have an incision on your knee. I mean, I had knee surgery, and I got something kind of flickering in that nerve. It's the human anatomy. So to blame something on a specific surgery, maybe not.
That's a good point. I like to tell patients, you cut any nerve, any part of the body, that there's a chance that nerve could grow back erroneously and cause phantom pain or discomfort. And so it's not necessarily an eye specific issue. It could be anywhere in the body issue. And that goes without saying. If you ask the experts in corneal neuralgia and pain that are seeing those patients all the time, they'll tell you that the majority of the patients they see are having corneal neuralgia from something else. Let's say putting a contact lens they caused a scratch, or that a hairbrush that broke a nerve. So most of their patients are non-refractive or surgery related. They're coming from something else, but it still is the same scenario. So to point it all at LASIK I think is unfair. It's sort of, you can, a contact lens wearer, could develop the same type of problem, or any patient that's never had contacts or glasses can develop the same problem. So I think it is important to sort of take these opportunities to educate the market and get ahead of it and set this, set the narrative on our terms, and, to help kind of dispel some of these myths. Any thoughts? I think we've talked a lot about corneal refractive surgery. I think that's where a lot of myths, started. That was where, the original laser eye surgery started, and refractive surgery was a boom to, for all these other technologies. What would you say that we should take and apply to, let's say, refractive lens surgery, or premium cataract surgery, or ICL surgery? Any thoughts that that we should learn from LASIK to apply to these technologies as they're sort of emerging, and maybe get ahead of some of these myths before they start?
I guess my thoughts on it are, for sure we need to learn the lessons, and I think it's keep it simple, speak the truth, and speak it often, because we'll get tired of saying it before people get tired of hearing it. And so just to me it's repetitive safety, efficacy, patient reported outcomes. And to button it up, I think we need to celebrate the patient reported outcomes, because that's what really matters, is patient perception. We started it with talking about 20/20, and it's really, you want people to be 20 happy. That's all that matters. Doesn't matter what that second number is. And if we can, use these patient reported outcomes to show that people love what they had done surgically, then the rest will take care of itself. And so I guess simple truths and happy patients are going to rule the day.
Well said.
I would say, Bill, on the corneal refractive, I think we've got incredible mousetrap. The mousetrap we have now, be it excimer laser or Smile, is so much better than what we had, let's say, 1995 through 99. So the mousetrap's better, massively less issues that we've created. If I take that and move that into refractive lens and refractive cataract surgery, we still don't have the perfect mousetrap. The perfect mousetrap would, be able to create planosphere and have an accommodative lens. We don't have that. So alternatively, you can either do multifocals, pluses and minuses there, or you can do, let's say, something like light adjustable lens, absolutely awesome quality of vision, but you don't and can't predict all three focal points for an individual eye. And you can do a little bit of blended vision and get them very, very close, and it works fantastic. I think it's the best procedure I've ever done. as far as trying to solve presbyopia and ametropia, but there are some people it's not perfect for. So we don't have the perfect mousetrap yet. So I think it's, undersell, overdeliver, and I think you'll have incredibly happy patients. If you oversell refractive IOLs or refractive cataract surgery, I think you probably put yourself in a little bit of a pickle. So I would just say, I think what Michael's saying, be honest about what we can provide and just take your collective experiences of what your patients have had and tell that story. And I think patients will overwhelmingly take that and adopt it.
Yeah, well said. I think you're right. I think just giving proper education of what things can and can't do, that alone should sell the current technology. I don't think we have to oversell it and set the expectations higher than what we can achieve. I think being realistic is probably, the best opportunity. And I think realistic is amazing this day and age with what we have. And so I think it's a good way to approach it. Well, as we're concluding this final half hour, any last thoughts before we sign off here, Mike?
The reason I got into ophthalmology, Bill was a big influence on me as I was going through residency. I wanted to give that shout out. But the reason why I got into ophthalmology at the beginning was the technology is amazing, and I'm just blown away with how much it's come, in the last decade that I've been in the field, and I'm very excited for what the next, 30, 40 years leads for us. The technology is just amazing.
I would agree. And I say, what we're providing today and what I'm doing right now, laser vision correction, absolutely love it. What we're doing with IOLs, we've never had as high of internal referral rates. Family members, siblings sending in siblings, spouses sending in spouses. We just have never achieved that level like we are now. And if I say the shout out goes to light adjustable lens, that we're selling quality of vision at a level we've never had before. I mean, multifocals, yes, work, but there are enough drawbacks that the referral rates just were never, at least in my practice, as high as I would have liked to have seen them. Now it's really become a game changer that the quality of vision is so darn good that it really impacts patients and they're willing to share that experience with friends and family.
Great. Well said. Well, thank you both. Thank you, Dr. Mike Greenwood and Dr. John Doane. Thanks for your thoughts and thanks for helping dispel some of the common myths in eye surgery and helping move the field in a positive direction. I appreciate it.
For more shows like the one you just listened to, check out the podcast channel on itube.net.